All right, all right. Focus, people, focus.
Got it.
All right, so almost talked to you guys, yesterday, right, about shock, right? So we won't talk about shock except maybe a little bit of clinical stuff at the very end, all right? This is a pretty short talk, pretty simple. All I want is to reproduce a table that I have right here on this board, piecemeal, by having you guys telling me all the information that's on there. All right, we're going to walk it through one at a time. So call them out. What drugs, drips, whatever, do we give our patients when their blood pressure is lower than we want it to be? Okay. Keep them coming.
Dopamine.
Milrinone, norepinephrine, norepinephrine.
Dopamine.
Close that damn book.
Can't use my resources.
Because you have it all. You have it all memorized already. Okay. Phenylephrine. Yep. Phenylephrine. I've got two more on my list. I got two more on my list. Have you seen us? You would be more familiar with this drug if you were in a unit that did post-op hearts. But you will see us do it, add this drug when we have a patient who's in some type of cardiogenic shock-like state. Starts with an M. Oh, is it up there?
Yeah.
Oh, damn, they got it. Never mind. That is Milrinone. So, hold on, what am I missing here? You got that one. You got that one. Okay, you got them all, except for one more drug that we use as commonly as dirt. Okay, you can't pretty much even get hospitalized without getting on this drug.
Fluid.
Okay, drug, not IV fluid. Drug. Okay, you can't even be hospitalized without getting on this drug, especially in hint respiratory season.
Albuterol.
And what else?
Steroids.
Steroids! Bango! Okay? Glucocorticoids, all right? Hydrocortisone. Hydrocortisone. Okay? And of course, don't ask me why, but when we're using glucocorticoids as a blood pressure supporting drug, we use hydrocortisone. When we're using glucocorticoids as an asthma drug, we're using prednisolone or solumedrol, and when we're using glucocorticoids as a croup drug, we're using Decadron, but they're reasonably interchangeable, all right? And certainly, when you have your patient on Decadron or prednisolone or whatever, and the nurse says the patient's 140 over 90, you're very used to hypertension as a side effect of these drugs, right? And unless it's outrageous, you just kind of discount it. But that same effect, when we have low blood pressure, is the therapeutic goal that we're after, right? All right, easy. So what now we're going to talk about how these drugs work mechanistically, all right? And then we're going to talk about, and we're just going to go down the columns, all right? And then we're going to talk about what those mechanisms do physiologically, and then finally we're going to talk about which drugs would you consider for which shock-like state, because they work differently, and some of them might be better drugs for different types of shock. All right. So epinephrine, how does that work? Not what does it do, but how does it affect its action?
What does it make the body do? Or what receptors?
On those receptors.
Beta 1, primarily. But it can do beta alpha at high doses?
That's not quite right. It does all catecholamine receptors at all doses, pretty much equally. All right. What's the other name for epinephrine? Adrenaline, right? When you're giving it in a syringe, we call it epinephrine. When it's coming from your adrenal gland, we call it adrenaline, but it's the same molecule. So think like Charles Darwin, all right? Adrenaline is our own endogenous catecholamine. We have three plus the central alpha four catecholamine receptors, right? But three of them that affect your blood pressure, right? And would it make sense for us to have evolved three catecholamine receptors and epinephrine if epinephrine didn't hit those three receptors? You know? No. Charles Darwin says no, it would not make any sense. Okay? All right. So it is a equal opportunity adrenergic agonist. All right? All receptors, all doses. All right? Now, what you just said, okay, you might want to repeat it for our next drug.
Oh, beta 1
Beta 1
at low doses.
at low dose.
Beta 2 now.
Not
That's
beta,
not really beta
not
2.
beta 2, no. But keep going. What's your other option?
Oh, and dope.
Well, yes, it hits your dopamine receptor.
Yeah.
Funny that, but alpha.
Alpha.
Okay, at high dose, dopamine is an alpha agonist. Okay, at high dose, and then of course also it is a dopamine agonist. Okay, all right. Now at high dose, it is still also a beta 1. Okay, that doesn't go away. All right, it's that the beta 1 effect kicks in earlier at lower doses, and the alpha then comes to the fore at higher doses. All right, and by the way, what's a low dose and what's a high dose? I'm not going to bother putting that up on the board, all right? Maybe because I don't remember myself, okay? Or maybe because I don't think it's going to stick with you, and I think it's more important for you to look it up when you're actually writing that drug, or let's be realistic, it's going to be on the computer screen when you order your epinephrine drip, right? Okay, norepinephrine, how about that? Oh, and by the way, the next time that you're tempted to say that one of these drugs is a significant beta 2 agonist, ask yourself, when was the last time you used it in asthma? And if the answer is never, then it will have little or no beta 2 effect, right? And have you ever used dopamine in asthma? Nah. Okay, unless they're really crashing and they have asthma, but they're also about to die and you're trying to get their blood pressure up, right? All right, norepinephrine.
It's more alpha.
Correct. It is a powerful alpha agonist. Okay, is it anything else?
I thought there was some beta.
There is some beta. All right, there is some beta 1 activity. Okay, it's mostly alpha, but there's definitely some beta 1. All right, dobutamine.
Beta 1.
Definitely lots of beta 1, a little bit of beta 2, but it's not a significant beta 2 agonist. We don't use dobutamine in asthma. Okay, vasopressin. Alpha, beta.
V1 and
Damn. I think you're remembering some of this from. I've probably had you in that chair, and I've been up here without the recorder, right? Okay. Yes. So, like dopamine, all right, it has its own receptor. It's called vasopressin 1 and vasopressin 2, and they have two very different effects, and those receptors have two very different locations. All right. Where is V1 located?
2. The heart.
No.
The vessels.
The vessels. Where's V2 located?
Kidney.
Kidney where?
Aquaporin.
I'm sorry?
And aquaporin.
Where are the aquaportin channels located?
The collecting duct.
The distal collecting tubules. Distal, no, the collecting tubules. That the final stop before the ureter.
Yeah.
Okay, whatever those are called. Okay, the last stop in the train there, and it opens up aquaportin channels for you to reabsorb free water. All right, and in that case, we call vasopressin what actually? It's another name. It's like epinephrine and adrenaline. What do we call it when we're referring to its effect in the kidneys? ADH, right? Antidiuretic hormone. I mean, vasopressin is the pharmacological equivalent of that, but it is it's our own endogenous hormone, antidiuretic hormone. All right. All right, milrinone. How does that work?
I don't know receptor. It's a
You're cheating
phosphodiesterase
again.
inhibitor.
It's a phosphodiesterase inhibitor, right? So milrinone, does not end in INE, it ends in ONE. And if it doesn't end in INE, it is not a catecholamine, INE. All right, it is not a catecholamine. It does not hit alpha 1, beta 2, or any other adrenergic receptor. It is, you're right, a phosphodiesterase inhibitor. Phosphodiesterase inhibitor. If you want to know more, like I told you to hit the pharmacology, no, the radiology textbooks if you wanted to know what the ADC was the other day. If you want to know more than this, hit the pharmacology textbooks. All right, but while the initial action is different, the downstream action involving G proteins and cyclic AMP and calcium calmodulin, see, I was leading up to it, okay? All right, is the same, okay? All right, so anyway, we'll get back to that. Phenylephrine,
Alpha.
yes. All alpha all the time, nothing else, all right? Pure alpha, all right? And then hydrocortisone. How does hydrocortisone work to support your blood pressure? Nope. How would vasodilation support your blood pressure? I don't think it would. If that's the only thing it did, and it doesn't do that.
Doesn't it just help like a stress response?
Well, yes. Under stress, your adrenals are going to pump out cortisol, right? That's your native glucocorticoid, right? It's kind of a trick question because the answer is I sure as hell don't know. All right. Do you know, Almas, how hydrocortisone raises your blood pressure? I think honestly we don't know in medicine. All right, it's been heavily researched. It is still being heavily researched. The nice pat answer that I learned in fellowship, which is too simple and is probably not true, like many other things, sounds good. All right, but if it's coming from me, you might want to doubt it. We do know that steroids. I mean, think about how steroids work in any way on any of its effect. We think of steroids as an anti-inflammatory and an immunosuppressant, but whether that cortisol molecule is circulating from your adrenal gland, whether you're eating a pill of prednisolone, whether you're getting injected with Decadron or Ciamedrol, those steroid molecules are circulating through the bloodstream, into the interstitium, to the cells, crossing the cytoplasmic membrane, crossing the cytoplasm, crossing the nuclear membrane, right, and acting as promoters and inhibitors of genes, gene expression, right, where they're going to upregulate and downregulate all kinds of gene products, right, and ultimately protein expression, right. Most of those products are involved in inflammatory cascades, all right. I learned once, this is the part where you should be skeptical because I myself am skeptical. I learned once that one of those proteins is actually involved in the formation of catecholamine receptors, all right, by giving exogenous glucocorticoids, you're going to increase the cellular expression of glucocorticoid receptors. All right. If that's true, it's it's an appealing explanation, right? But I think it's oversimplified. I will say that we give hydrocortisone. Well, you know what? I'll leave that in a minute. Leave that for a minute. All right. So who knows how exactly it works, but something about increased protein expression. And maybe, increase adrenergic receptor expression, but I think that's questionable.
Is the dosage the same that you do for asthma, like 1 mg per kg, or you do higher doses?
No, it's not. Well, first of all, hydrocortisone dosing is different than methylprednisolone dosing. Okay, and so we give it by meter square, and we give a higher load, and then maintenance Q6 or Q8 after that, right? and it's 100 per meter squared per day. I think 50 per meter squared load, and then 100 per meter squared per day divided Q6 or Q8. All right, and that is way, way above, that dosing is way above physiologic replacement. Okay, all right. Now, what are the physiologic effects of all of these mechanisms now? All right, epinephrine. What does epinephrine do? Okay, but it is a blah, blah, blah agent. I. It is an ino.
Oh, an inotrope.
Inotrope. All right, so it's an inotrope, and it is also a what else? Now think about the receptors. What does each receptor do? What does the beta 1 receptor do? That's your inotropic receptor. Okay, that's the one that's on your heart. Okay, and it's responsible for a whole bunch of effects on your heart. Okay, one, it makes your heart squeeze harder. Okay, two, it makes your heart squeeze faster. All right, we call that chronotropy. All right, three, it speeds atrioventricular conduction. That's called dromotropy. And four, it actually aids diastolic relaxation and cardiac filling. That's called lusotropy, L-E-U-S-O tropy. All right, but I think of it as L-O-O-S-E, loose. It makes your heart loose. All right. We abbreviate all those effects, the chronotropy, the dronotropy, the lusotropy, sort of fold that into inotropy. But strictly speaking, inotropy just means stronger pump. All right, so it's an inotrope. What else is it, though, peripherally? Beta 2 is a vasodilator, and importantly, it is also what other dilator? Hello, albuterol? Yeah. Bronchodilator, right? Have you ever had a frightening asthmatic show up in the ER and you're the first line of defense? Like a kid who's gasping, who's about to lose consciousness? Okay? They don't conveniently come with an IV in place. Okay? And they're so damn tight that you can give them all the amount of albuterol that you want and it may not get down. Okay? So we will give them epi. Okay? Because of the beta 2 effect of epi. All right, we rarely use epi for asthma up in the ICU, but that's because either we've opened them up or we have IVs and we have better options. But if you don't have IV access and the kid's about to die from asthma, injecting them with a shot of epi may be life-saving while you get other things going. All right, so it's a and then what? And then alpha. We forgot about alpha. Broncho and vasodilator. And then what does alpha do?
Vasoconstrict.
Yeah, it's a vasopressor, all right, or vasoconstrictor. Okay. Now, net effect on the vessels is constriction, all right, for epi. So the alpha effect overcompensates the beta 2 effect on the vessels, okay, but it is a bronchodilator. So it's an inotrope, bronchodilator, and a vasoconstrictor or vasopressor, all right? Since we've now figured out what all of the catecholamine receptors do, all the other catecholamine effects tend to march forward from that, right? Dopamine at low dose.
It's an inotrope.
Yeah, inotrope at low dose, inotrope at low dose, and then at high dose, it's also obviously a vasopressor as that alpha agent comes into play. Okay, norepi. Yeah, it is first and foremost a vasopressor, but it does have inotropic effect as well. It's just that it's weaker. Okay, dobutamine. Yeah, It is a strong inotrope. Okay, and potentially can cause peripheral. It's not an effective bronchodilator, but potentially could cause some vasodilation. That's not typically a prominent effect, but if you're giving dopamine as a sole agent, you may not have the effect on blood pressure that you want, raise it up, and it may have something to do with that. Okay, we tend to use dopamine along with something else. Vasopressin now. Okay, so now our two effects, right? One, it's an inotrope, right? That's why we call it vasopressin. Come on, guys, wake up. It's a vasopressor, right? V1 is a vasopressor. Okay, and increased free water reabsorption in the kidneys. Okay, all right. Milrinone. This is a neat drug because this is a unique combination of effects. Okay, this one you just got to know because you don't have the catecholamine receptors to sort of point you as to the physiologic effects. All right, one, by doing this, all right, and having that G protein, cyclic AMP, calcicalmodulin downstream effect, you are an inotrope. Okay, but then also it decreases. It is a vasodilator. It decreases systemic vascular resistance. All right, and that is a useful combination, okay, to have in a particular clinical shock state. All right, phenylephrine and pure vasopressor. All right, there is no inotropic activity here. And then hydrocortisone is just kind of whatever other witch's brew of catecholamines that the patient has secreted or been injected with, all right, is gonna come into effect, right? And so we give hydrocortisone when we've started our dopamine or started our epinephrine or started both and ramped them up and maybe are thinking about adding vasopressin, thinking about adding norepi or whatever, and it's just not working. We give the hydrocortisone to make our catecholamine resistant shock amenable to catecholamines. All right. So whatever other combination of inotropes and vasopressors that you have circulating are going to be more effective once you give the hydrocortisone. Right. So the physiologic effect will really be dependent upon the other drugs that you're combining with the hydrocortisone. Okay. All right. So now let's think about some shock-like states. Okay. That you might pick one or the other drugs for. All right. How about your febrile neutropenic teenager coming in? They're initially out on the floor, but they've gotten bolused because the blood pressure was, 70/30. It responded nicely up to 100/50, but then a couple of hours later, you're sagging again. You're giving another bolus. You're moving them into the PICU. Okay. Blood pressure 70/30. All right, they're tachycardic, they're flushed. They're still talking to you, but they're flushed. They have warm shock, sure, aka distributive shock, aka septic shock, aka vasodilated shock. We have so many different names for similar phenomena. All right. So what's our main problem from a pathophysiology standpoint here?
They're too dilated.
They're too dilated, right? They're vasodilated. So what's the solution? What's the physiologic solution that you're after? You want a vasopressor, right? And what about inotropic support? Is that useful in septic shock? It could be. It could be. Okay. Now, why in particular? Well, because it's really rare in bad septic shock to not have, especially in pediatric bad septic shock, to not have some element of cardiac dysfunction. All right. Blood pressure, systolic and diastolic, are low in septic shock, right? But which is lower proportionally, systolic or diastolic? Diastolic. When are the coronary arteries perfused? Diastole. Okay. So yeah, obviously inotropic support may be helpful, but certainly vasopressor support, more of that and that first. Okay. All right. One other thing that I think is helpful for you guys to know. All right. Dopamine and dobutamine, okay, are commercially made in pre-mixed bags. They have the shelf life stability that epinephrine and norepinephrine don't have, okay, and phenylephrine does not have. And so what that means is in every crash cart in this hospital, you have a bag of dopamine, okay? And so if you're in a big fat hurry to hang something, all right, you can pop open that crash cart, grab the bag of dopamine, do the Hail Mary pass to the nurse, and have that thing hung in a minute, okay, and going into the patient, all right? So when you're really hurting, okay, you can get dopamine, and dopamine in almost any shock-like state, you can get it on board fast, all right? And that may be all you need, okay? But if you need more, or if the dopamine is just temporary and you're buying yourself some time, all the other drugs, the epinephrine, et cetera, that then you got to sit down to Epic and do your calculations and send it off to pharmacy and wait for it to get tubed over, and that can take too long, right? So whether it's septic shock or whatever, dopamine is your fastest answer. But there then may be more elegant solutions if you're adding a second drug or getting a better drug, and the dopamine is just temporary. All right. So for septic shock, for dopamine, maybe septic shock. Question mark for a fast agent. All right, because remember, dopamine in high dose does give you that vasopressor effect, all right, and certainly gives you inotropic support as well. Okay, but what would be a better drug, a more elegant drug for classic vasodilated septic shock that gives you lots of pressor effect and some inotropic effect? Norepi, right? So definitely norepi for septic shock. Okay. And sometimes maybe epi, all right? So it kind of depends upon, this would be like your best, your classic answer, okay? But it all depends upon the clinical response and the degree of urgency and in what order you're adding these drugs, all right? If they just need a little, right, and you grab that bag of dopamine and they're on 5 or 10 of dopamine, that may be all you need, and you never get any higher than that. But if you get up to 15 of dopamine, God forbid 20 of dopamine, right, now you need to add a second drug. And it might be epi, it might be norepi. Which one, okay, will depend upon what the patient is then doing at that point, okay? If they're still red as a beet, okay, still have a piss poor diastolic pressure, still have a flash capillary refill, bounding pulses, okay? So then you still need a lot more pressor effect, right? Because you're just not enough on the dopamine. And so you would add which one? Norepi. But if, on the other hand, you've given them that high dose dopamine, all right, and now they're still shocky, the blood pressure is low, but at least the pulse pressure has narrowed, and peripherally they're kind of cool at this point with a little delayed cap refill, thready pulses, right? Now they're clamped down. You've already got your pressor effect, all right? You need more inotropic effect. So which drug then? Epi, right? You'll still get more pressor effect, but epi is definitely a very strong inotrope, right? So that'll depend again upon your clinical scenario, all right? And when we say septic shock, really this is true for distributive shock. What's the other kind of distributive shock that we talk about? You're right, but that's not what I was going for. What's the third kind of distributive shock? Anaphylactic shock, right? So epi for anaphylactic shock, all right? We like epi for anaphylactic shock. Why? Because it is a vasopressor, it is an inotrope. Both of those solutions are problems in anaphylactic shock. But what else is epi? Bronchodilator, right? And of course, they're very wheezy, right? So it treats everything that's wrong with anaphylaxis. So epi is a great drug for anaphylaxis, all right? All right, now what about, and so vasopressin, okay? This is a drug that probably Julie grabs as a number 2 and I grab as a number 3, and I don't know about Almus. But vasopressin is, again, a vasopressor, right? So it would be a good drug to add to your septic shock patient, to your anaphylactic shock patient for that extra vasopressor effect. Again, if they're warm. But make sure that if you're giving them vasopressin, you're also giving them epi, or you're giving them something that gives them inotropic support too. Because to have just somebody, a pure vasopressor effect and no help to the heart is going to massively increase your cardiac work and may be counterproductive in short order. It might bring up your blood pressure momentarily, and then half an hour later you're sagging again because the heart's just given out. Right? It doesn't have the inotropic support it needs in the face of very high peripheral clampdown. All right, what about a class of patient that we don't often see here in the PICU, in our PICU, because we don't have this type of surgeon at Loyola? Cardiogenic, and in particular, not like necessarily well, actually, this would probably work well for like a cardiomyopathy kind of patient. We do see that kind of patient. But a cardiogenic shock, post-op heart, right? A heart that, let's imagine what a heart has just gone through, all right, in cardiac surgery, all right? It has been infused with a cardioplegic hyperkalemic solution causing an arrest, okay? It has been cooled, okay, with cold fluid, all right? It has been stabbed and cut through with a scalpel, all right? It has been poked with a suture needle multiple times, all right? It has been made hypoxic for an hour, okay, acidotic for an hour, and then after all of that, it's frickin' electrocuted, right, to restart it, right? So is this heart a happy heart? No, it's not a happy heart at all. Is this a heart that's going to be working well? Probably not, right? So what effects are we going to want for a post-op heart?
Increase the contractility.
So definitely inotropic support. Now, are we going to want vasopressor effect for a post-op heart? No, we're going to want to avoid that. The last thing we want to do is increase the work that this heart has to pump against. All right. So what do we see here that's a real powerful inotrope? Yep, milrinone. And another one that's like purely an inotrope or nearly purely an inotrope? Dobutamine, right? So dobutamine is going to be an important post-op part 1, and milrinone is going to be important post-op part 1. Okay, what other particular advantage, unique advantage, does milrinone have? Yeah, exactly. So not only are you not increasing cardiac work, you're actually decreasing cardiac work. So the modern day solution to the post-op heart most commonly is going to be dobutamine and milrinone. All right. Now, there's rarely one way to skin a cat, right? Different doctors have different styles, and we already know that I use vasopressin a little less often than Julie. I use different ventilator modes more often than Julie, etc. Right? And different, cardiac surgeons have different, favorite ways to do this, all right? And even different institutions. But the last couple of institutions that I've been at that have done hearts, dobutamine and milrinone have been the favorite combination, all right? If you want to go old school, all right, epi and nitroprusside, right, which is a potent antihypertensive, okay, and causes vasodilation and decreases cardiac work. All right, this is what people have the amyl nitrate, right? When they're having a heart attack, you just crack it and inhale. That's how that works. Okay, all right, and then one more. Okay, teenage lumberjack. Okay, chops down a tree. It falls on him in his lower back, and he has a spine injury. And he comes in massively vasodilated and hypotensive. Fluid, and
Well,
you know, Phenylephrine, right? It's the one. Phenylephrine is nearly the first drug that the adults do for shock, but we like more inotropic support in all shock-like states, and so they use norepi. Well, it's a heavy alpha agent, all right. But I sometimes see them using phenylephrine. I sometimes see them using phenylephrine nakedly without anything else, and I'm like, what? But yeah, spinal shock, where you have loss of adrenergic tone because of transection of the sympathetic chain to your peripheral vasculature. Basically, you're taking the place of the sympathetic chain by circulating alpha to the vessels. All right. So this phenylephrine would be the only time that you'd see us use epinephrine for spinal shock. All right.
What about if you have like ECMO available? Do you need as much on your drips? I'm just, I don't know.
Oh boy, what a what a different talk.
We don't have to get into the details. Has that like changed management of post-op?
ECMO is just such a total different animal. Whether you go on ECMO for heart failure or pulmonary failure, once you're on ECMO, it's all the machine. All right. Then if you still need to be on these drips when you're on ECMO, then you're on the wrong kind of ECMO. Okay. There are different ways to hook up ECMO that will give you either lung support or lung and heart support. And if you're on just the lung support ECMO, which is called veno-venous ECMO, and you're not on veno-arterial ECMO, which gives you both lung and cardiac support, and you need to be on a lot of these drugs still because your blood pressure is low, then it's time to call the surgeons to revise your cannulation and give you an arterial cannulation. Right? But once you're on veno-arterial cannulation, the need for all these drugs goes away. All right, because it's the machine. The machine is not sensitive.
Go off the ECMO, then that's
When it's time to, so we don't go off ECMO. What we do is we trial off ECMO, and what that means is we get all of our whatever drugs we need ready, okay, and then the machine keeps running, but we clamp the machine off from the patient, okay, and we will go up on our ventilator settings, and we'll go up on our epi drip or whatever else we have, and make sure that they're okay to come off ECMO before we actually then commit and cut away the cannulas and cut away the circuit. Because the last thing you want to do is to cut away the ECMO and then realize, oh, my bad, we weren't quite ready. Okay? All right, I should stop recording because we really don't need to include that.